at the beginning of COVID was kind of, this thing that happened in China, and we weren't too sure of how badly it was going to affect South Africa. Is it something that was made up? And then all of a sudden it hit us quite hard. So obviously the operating procedures and all that kind of stuff, changed quite drastically, whereby going to treat patients with gloves and, kind of the normal PPE that you would don to treat what we would say a normal patient, a day-to-day patient, obviously drastically changed.
Obviously when COVID came in, it was a little bit of a crazy manic time, as we suddenly went into lockdown and trying to, figure out and juggle how we're going to do that from a operational perspective, but obviously also from an administrative perspective, how the cleaning of stuff happens and, just how they have to don different equipment prior to going on a call. So that was really big adjustments for crews, and a lot of anxiety caused through those stages because no one really knew initially. We don't know, firstly, how these patients are going to present. At the start of COVID, that was very uncertain for us, as what are we finding, how they're going to present, what is the best way to treat them, can we treat them in the back of the ambulances as a confined space, or are we really just loading them and taking them to hospital because we don't want to do too much interaction with these patients.
I remember seeing the first couple of crews going on a COVID call, and I felt for them. I was like, or new staff that have, I felt for them. I'm like, sure. And I'll be honest, it was rather you than me at the moment, because I need to get used to it, because I was in a different sector. I was in the response side where I wasn't transporting these patients. It's one thing treating a COVID patient, but having them in a confined space in the back of your ambulance for a long period of time can also be quite daunting.
Kumbulani and myself were actually partners together at the time, and we got a call to go to Muizenberg for a declaration of a person who had suspected to have died from COVID. So obviously, although the person wasn't alive, there was still this fear of, oh, they have been taken by COVID kind of thing. So obviously we arrived and we were chatting about it en route, and we said, oh, how are we going to do this? Hope we don't have to get too close. Hope we don't have to enter the house. And we obviously had our PPE that we had to don, and we were very apprehensive, but upon arrival we were actually very pleased that another ambulance service had already been there. So that was our first call, and then since then, very soon after, Kumbulani and myself started doing more calls, COVID calls, where again we were donning the PPE and thinking, oh, this is so new, this is such a mission, putting on all the clothing, but it soon became the norm. But it was very nerve-wracking. Yeah, we didn't know what to expect or how close to get or how long to spend with the patient. We wanted to be in and out as quick as possible. We didn't want to linger longer unnecessarily.
On our first COVID call, I was very nervous. Anxiety, the level was very high because it was our first call and our first patient to treat at the pandemic thing. So we were very nervous. Having a wonderful partner like Fiona, we talked about the call as we were going to it. We were driving, going there. We spoke about it. We managed to calm each other down. And she told me that we don't have to stress that much or worry that much. We have our full PPE, so it's going to protect us. And we'll clean as we go in order to kill all the bacteria and the germs that they say COVID-19 has.
I have not liked this last 2 years, not at all. Okay, my own anxiety levels have been very high. So we would go out, do a physical assessment of the patient. It was quite interesting because so many times we decided that it probably wasn't COVID, and then it turned out to be. And so many times we decided that it probably was COVID and it turned out not to be. But yeah, we were out there all the time. We saw Fiona and Kumbi in their level 2 outfits. The stress levels go up significantly just in the fact that you have to don that. That was horrific.
Part of being in EMS is calming and reassuring a patient. Now, when you can't calm and reassure a patient because you can't touch them, that, you know, it's difficult. Half our job is done when we can calm and reassure a patient. So a lot of crews were finding that quite distressing, having to go into houses, firstly don full PPE, so the patient can't see them properly. It's hard to communicate, it's hard to talk through your masks and all of that. You can't form any physical contact with the patient. Everything has got gloves on.
It was very frustrating because for me, I'm particularly difficult in hearing. So for me, I found I was shouting to the patients and then I couldn't hear them because we had the N95 mask on, the safety glasses and a face shield. So in between perspiration, a noisy environment at times, and not hearing your patient and them not hearing you, it was incredibly frustrating. And also in terms of exertion, you know, if you had to carry a patient down the stairs or wherever, you had all this PPE on. So you're getting hot and irritated potentially. So you also had to be extremely patient, more so than normal. Never mind now you're not able to touch the patient when reassuring them. So that was quite interesting because, yeah, you had to actually tone yourself down in order to be better for your patient. And then not touching. At some stages we were wearing double gloves, some triple gloves at times, because again we didn't know how this virus spread, or we'd wear 2 short gloves and then long cuff gloves. And as we were finished with, let's say, assessing the patient, we'd take a pair of gloves off work, and then when we started driving we wore our final layer of gloves. So yes, touch became an interesting thing, and it became very impersonal in a way. I just tried not to rush things, you know, because although that impersonal feeling was slightly reduced with the PPE, then I thought the least I can do is try not to rush things. If it's not an emergency, take our time, take a minute to chat, have a moment. But obviously if it's an emergency, then we've got to rush and be prompt and efficient. But if not, if there's no touch involved, then just give the patient the time at least.
You're not able to really calm and reassure your patients. You're not able to reassure family because we don't know. We don't know. We can take you to hospital. Are we able to find you a hospital that can accept you? The hospitals are filling up.
If we were dealing with the parents when it came to taking them to hospital potentially, and the children cannot go with, or the children want to hug and kiss and say bye-bye, then it became hard to say, maybe don't hug your mom or your dad so close, or don't you want to put a little mask on, or just give an air hug, an air kiss kind of thing goodbye. So that was more, not so much treating the children from COVID, but as you say, the emotional effect maybe when saying goodbye to granny or grandpa going into hospital or things like that.
We had to clean more than 2 times. We had to wipe down everything after every call, ozone, use the atomizer as well. So that was a learning curve for all of us, just to be clean on the COVID side and maintain everything for every different patient that we have to face for the day. With teamwork, everything goes smoothly.
It was very interesting to see how we developed, but you had to keep changing accordingly.
We learned as it progressed and learned what was required and what wasn't really required, what made a difference and what didn't make a difference. We now have an atomizer, which is a non-corrosive atomizer. It's a little gun-like unit, and it's got a solution in it, and they spray it. Very fine mist that goes onto everything, and that really, by the time they finish on their call and get back to base, that has now dried nicely. And then we have what is called an ozone unit, which is at the office. They take it out, they put the pipe into the vehicle, run the vehicle for 5 or 6 minutes with the ozone running, and that goes through the aircon, and that neutralizes everything as well.
Definitely in the beginning, a lot more medical calls. Because of the lockdown, people didn't go really out. There was not really that much assault, traffic accidents, things like that. The medical calls, like your SOB, the strokes, those kind of things still happened. As the levels started being lifted, we saw the trauma calls coming in slowly again.
We were replacing a lot of what the GPs were doing because they weren't risking themselves to have their patients come into their rooms or them going to do home visits. So a lot of the time we were doubling up on general work, but then going to patients who said, oh, my GP said I must phone you, or I rang the GP's rooms and they say, you know, I must see you first before going to the GP. So that was very interesting. And then at the same time, we were in an unknown, but yet kind of expected to provide advice.
Most of them, they were panicking. It was like panicking, anxiety. Whenever it's normal for us to cough, it's normal for us to have flu and other things. Those are normal sicknesses that we daily have. But most of the people, when they start coughing, sneezing, and having like 1 or 2 symptoms of COVID, they will start panicking and thinking that it is COVID, while some of them it's not.
During the HIV/AIDS pandemic, there wasn't social media. So you heard rumors, but you weren't bombarded with stuff all the time. Whereas now, there's horrific fear and anxiety that goes around because you're bombarded with it everywhere, social media, everywhere. I don't recall us ever, I mean, obviously we did treat people for anxiety, but it wasn't the norm during the 90s and 2000s. Whereas now, a vast number of patients have extreme anxiety. And I think that it's because of the coronavirus pandemic.
We were finding that a lot of it was a lot of anxiety. So there was the unknown of, I've read 100 things in a newspaper and, I'm going to land up on a ventilator. And you get there and they're perfectly fine and they're just more anxious than anything.
People, when they phoned, there was so much more anxiety because we had this illness out there everybody was afraid of. And all of a sudden, people also, a lot of false information went out. So you would get people that were so nervous thinking that they are going to die. And then at the end of the day, SATS readings are 99%, they're all good. So you had to calm them down and, talk them through and say it's going to be okay at the end of the day.
A lot of people were getting nervous about what they'd obviously seen or read in newspapers, TV, etc., media. And then the president would say some more things, that would spook people. So suddenly we had to calm and reassure the patient about something that we weren't really calm and reassuring ourselves. We were having to calm and reassure ourselves at the same time. So it was very interesting. But I found that a lot of them, unless they were really severe and needed hospitalization, a lot of patients just needed calm and reassurance, saying, you don't need to go to hospital at the slight of a sniffle or a sore throat. Just we need to calm down, think a little bit here, and take it one step at a time.
With the very first lockdown, where we were at the highest level, we had a lot of respiratory calls. And with that also came the anxiety calls. And because everybody was so scared of this new thing called COVID, there was this fear. So they were short of breath, but the anxiety actually even pushed that respiratory issue higher and higher.
We found that we were just going out to a lot of anxiety-related things. So we popped in another procedure where if it sounded like it was an anxiety-related call, the control room would forward over to me. And I would personally phone the client or the patient themselves, find out what's going on.
There were complete new protocols in place. All of a sudden we had these flow sheets where you had to ask people more questions than that you normally would to establish basically, do they have COVID symptoms or not?
If it was life-threatening, we would dispatch a vehicle immediately. But once talking to them on the phone, you would find that, it's more anxiety related. You can hear that the way they're talking over the phone, they're not gasping for air. So you could pick up things and techniques on the phone.
We had to start sifting out severe cases because it was the hospitals were filling up. So if you didn't need to go to hospital, we're not going to take you because there's no place at the hospital. I remember at one stage we were phoning up to 9 hospitals to see if they had bed availability for a patient. So we were phoning from the deep south right through to Hermanus area to try and get bed space. And they just would say, no, full, no, full. If you suspected COVID, full, full, full. And so it became a case of we have to triage who takes priority, and we can't take everyone to hospital.
Mostly, I would say predominantly for our staff and those that got COVID, which was really, really few, it was bed rest, Panados, high vitamin dosage. and staying hydrated. You know, some ended up with a secondary infection with get some antibiotics after that. We've been very blessed, very, very blessed with our staff in COVID. Firstly, on the amount of staff that got it, and secondly, on their recovery.
So I did pull some statistics. I ran it from about May, kind of mid-May 2020 to June 2021. We had attended, on our records, we counted about 1,100 PUI cases that we had responded to. PUI would be classified as a patient under investigation. So someone that has got symptoms of flu-like symptoms or COVID symptoms that hasn't had a test. I worked out to about 30% of those 1,100 cases were actually positive cases. A lot of people, like I say, they were happy to stay at home, rather do their home treatments, rather chat to their GPs, not feeling so anxious, oh, I've got COVID, I need to go head to the hospital because of the million things that they've read. You know, they're diabetic or they're hypertensive and they have to go through to hospital because they've been warned, you know. But in actual fact, they managed to get through it and they're perfectly fine. They might have some mild symptoms that they can manage at home.
Adults with comorbidities have certainly had it worse, but I think it's been pretty much across the board as to, it's like the luck of the draw. You know, some people had it really bad and had no comorbidities, and some people had lots of comorbidities and actually were quite lucky.
It was generally the mid-aged, you know, between the ages of 40 and 70 that were treated for quite severe COVID. Obviously, the elderly, you know, they have obviously more comorbidities. Personally, I didn't treat very young kids for very, very severe COVID.
Most of the elder people were the older ones that we've treated.
It was definitely people with comorbidities. We were seeing very few healthy people needing hospitalizations. Don't think I even treated a child under 18 with COVID in the 2 years here. So for me, it was older people, 60s and older, that were suffering from COVID.
I can't say that I've treated a lot of younger people for COVID. I've treated some, but I wouldn't say it's a massive amount. I think all the serious breathing problems have been adults, older people.
The younger kids, symptom-wise, even though they had bad symptoms, not all of them necessarily ended up going to hospital. It was something that they could quarantine at home, maybe just speak to their GP again, you know, given some medication to assist with the healing and building up the immune system. With the cases hospitalization, definitely from what I know on my shifts, more older, middle age and up.
Palliative medicine has actually boomed. I think a lot of it you could have that were manageable at home. There were very few cases, and a few of them still stick out, where you walked into a room in a house and you knew, hospital, this needs hospitalization. You could just see if people were massively short of breath or fatigued, not able to breathe, etc. You could see the cases immediately, but a lot of them, I think, it was panic and fear done by TV, social media, etc. And a lot of it just needed to calm and reassure and stay and treat at home.
We got our cases where you would have your palliative care patients or patients that absolutely outright refused to go to hospital. And you know, you would do your best trying to convince them to go to hospital. You know, the very, very sick patients, which, you know, palliative care, they've got their own palliative care doctors at home, and they were like, no, we're not going to hospital. If we land up on, you know, a ventilator, we don't want ventilator you know, we don't want to be on a ventilator, we don't want any advanced procedures done on us. We found that a lot. And the palliative care doctors in the area that were assisting with us were absolutely phenomenal. They really put our minds at ease.
In the early days of COVID, not touching, that was very real. I think most of us have actually let that fall by the wayside. We're wearing gloves, we're wearing protective equipment. That reassuring touch is just so important, both for the patient and for us.
We normally used to have a lot of family come with us to hospital, but now obviously hospitals weren't letting family in. So that was also quite interesting. We had to have the family members say bye-bye to each other before we left and transport alone because they couldn't come. So that was also very tough because some patients, it might have been the last time they would have seen them. And people also couldn't understand why they couldn't come with. And we said, but that's just what the hospital's rules are. So there was that kind of separation. We battled sometimes for people to say, we had to say, we've got to go now. We can't stand here saying bye-bye for 20, 30 minutes. And people found that very hard.
I've learned to be more open about what's happening with people. So previously we would take somebody to hospital and the family would follow in the car, and we'd possibly have one family member in the vehicle, and we say, look, you know, we're doing our best. And in your heart of hearts, you know that this is going to be the patient's not going to survive, but you wouldn't generally say it. But you say, you know, we'll do our best, and that'll be it. And during COVID, we've gone, because we can't take a family member and they can't go into the hospital. So at the time of loading a patient, we've looked at the family and said, look, you need to say your goodbyes now because you probably won't see your loved one again. Or else we are looking at a patient and, you know, discussing with the patient who might be fully alert and the family and say, look, we can take you to hospital, but it's not going to change the outcome. You're probably not going to survive this. So your choice, do you want to go to hospital and be alone, or do you want to stay here with your family? And most people have said no, they'll stay home with their families, and, you know, and we sort of guided them through that, and obviously being as gentle and as caring as possible, providing pain relief and comfort as much as possible, and that's been the way it is.
A lot of things can actually now start to be managed at home. I think if families are not allowed at hospitals, I think people were seeing the relevance of being treated and potentially dying at home, but dying with family and loved ones at home, rather than, yeah, you get to hospital, but you're going to be alone if anything happens. So that has also been an interesting shift to see people be open to now being treated at home for certain things, whereas before we were so quick to go to hospital. But now actually there's been a shift that, oh, we can actually stay at home and if it can get treated at home, then why go to hospital kind of thing.
We found that a lot of the medics, you know, what we would, myself and my other colleagues would say would be, it's COVID anxiety within the paramedics as well. So you might not necessarily notice it, but you've been to 5 COVID patients over the last 2 shifts and you're a little bit more edgy.
Obviously, we work with a lot of people that do, at the end of the day, pass away. But this was just, there were so many of them that yeah, definitely left the impact on yeah, me as a person. We always had this bond at the office, and all of a sudden, we're not allowed to get close to each other. There's the social distancing. So yeah, the times got a little bit strange and lonely at times. Because there wasn't that interaction every day with your colleagues that you were used to have.
There's 3 very distinct age groups. There's the kids, the young people, who pick up on their parents' anxiety. During this pandemic, it was the first time in all my years on the road where I've actually had to sedate a child having a panic attack because there was just no talking him down. The older age group suffer with extreme loneliness because their families are not, you know, they haven't been able to see their families, people haven't been able to visit them. That's been really tragic. And the adult age group, dare I say, you know, old people obviously are adults, but the middle age group, the sort of working age group, are the ones carrying the can. They're the ones carrying the financial losses, worrying about their parents or their children, their houses, you know, worrying about the whole family. So it's 3 different types of anxiety. So in that working age group, interestingly, the vast majority of patients that I've seen just for anxiety have been men, and it's normally the slightly older ones, sort of 35 to about 70-ish, having complete panic attacks, which is something that they've never experienced before, and we don't see that often. Obviously, it has affected some ladies as well, but the majority have been men having the hyperventilation syndrome and that sort of panic. The ladies have been, it's more anxious, overreacting when things go wrong with the family. So when a child gets a little bit ill, you know, instead of just dealing with it, they're sort of becoming hugely emotional.
We find now still anxiety even after COVID, but it has decreased a bit from right in the beginning where it was like a lot of anxiety calls.
At this point, I think that the psychological damage that has been done by COVID possibly outweighs the medical damage that's been done by COVID.
What I've learned is that not to let my anxiety get the better of me over these situations, because that was hard in the beginning. And I think that was hard for most people experiencing COVID on a personal aspect as well as on a work aspect. And that we can get through this. We can and we will get through this pandemic.